Hello everyone, you're watching sqadia.com. Just a little question. Do fish have scales or humans do have scales too? Interesting, isn't it? Have you seen humans with fishy scales? Seriously? So, today our topic is psoriatic arthritis, and why I'm mentioning these fish scales actually that the classical lesion of a psoriasis arthritis is a silvery scale lesion which resembles scales of the fish. So, we will be going through the general characteristics of psoriasis, pathology and clinical feature, investigation, and treatment of psoriatic arthritis. A psoriatic arthritis is characterized by a seronegative polysynovitis, erosive arthritis, anesthetitis, and dactylitis, and significant incidence of sacroiliitis and spondylitis. This is actually inflammation of synovium. There's erosion of joint, that is erosive arthritis. Necessitis is actually inflammation of the tendons. Dactylitis is mainly the large and small interphalangeal joints get inflamed, and the insignificance of sacroiliac joint. That sacroiliac joint is actually inflamed, and there is intervertebral joint inflammation as well. If you see it over here, this is a classical picture of psoriasis, and the why I mentioned is the silvery scale lesions. If you see, it's quite pink and silvery scaly lesions are present, which resembles the scales of the fish, certain type of fish actually. The prevalence of psoriasis is 1 to 2%, but only 5% of those affected will develop psoriatic arthritis. Now there's a difference. Having a psoriasis, that does not mean you will get psoriatic arthritis. There is very small population of patients with psoriasis who are already on multiple medications that they eventually develop a complication of psoriasis resulting in a psoriatic arthritis. Now this is another picture which is showing a patient with psoriasis who has lesion on the bilaterally on elbow and on the right forearm as well. As with other spondyloarthropathies, there is a strong genetic component. Patient often give his family history of psoriasis. 60% of these with psoriatic spondylitis or sacroiliitis have HLA-B27. That is, their human leukocyte antigen B27 is positive in 60% of the cases. In next other 40, you may be negative, but they can still have psoriasis. Coming to the pathology, what are the joint changes which actually occur? There is chronic synovitis, increased inflammation of the synovium with cell infiltration and exudate, going on to fibrosis. Now, if you see it over here, can you see the disfigured fingers of this patient? And if you see on the X-ray, there was erosion, synovitis, and swelling, and eventually the joint line has actually deformed. Due to erosion of the joint line, this deformation of the joint which occurs resulting in the malunited or malrotated joints. Cartilage and bone destruction, which may be usually more severe than usual cases. Then other clinical features. Now remember, psoriasis itself is another topic, but psoriatic arthritis has actually all the patients of psoriasis could have arthritic complications or presentation related joints can be labeled as psoriatic arthritis. These clinical features include arthritis with the distal interphalangeal joints, asymmetrical swelling of 2 or 3 fingers may be due to a combination of interphalangeal arthritis and tenosynovitis, asymmetrical large joint oligoarthritis, patterns mimicking rheumatoid arthritis or ankylosing spondylitis, sacroiliitis or spondylitis, and ocular inflammation. Investigations include, first of all, you need to have radiographs. If there is anything involving joint, first and foremost investigation is radiographs. Then others could be CT if you want to assess the bone properly, but if we want to assess the soft tissue or the joints and other things, then probably the MRI is the investigation of choice. Then the first is X-ray of AP and lateral view. If of the hand, they will show severe destruction of interphalangeal joints, the hand and feet. In X-ray of the pelvis, there will be sacroiliac erosion is fairly common and mimics ankylosing spondylitis. Now, the special test would include RA factor, which is almost always negative. And why we need to get it? Because rheumatoid also affects the small joints of hand. So once we are making the differentials, we need to differentiate psoriatic arthritis from rheumatoid arthritis and osteoarthritis. Then HLA-B27 would be positive in 50 to 60% of the population. What are the differential diagnoses? Now, differential diagnoses are actually based on whether it's the metacarpophalangeal joints involved, wrist joint, or radiocarpal joints are involved, or interphalangeal joints are involved. Then there are different osteoarthritis, rheumatoid arthritis, and psoriatic arthritis. If only one of the joint, only one metacarpal or one radiocarpal joint is involved, then you must be thinking of acute gout deposition as well. And differentials, I've already told you, these include RA, ankylosing spondylitis, and other seronegative arthritis. Now once you diagnose the patient has psoriasis and now has developed psoriatic arthritis, what is the treatment? Treatment includes topical preparations and NSAIDs to relieve pain, immunosuppressive agents such as methotrexate and TNF inhibitors, tissue necrosis factor inhibitors, the inhibitors of other cytokines such as interleukin 17, 12, and 23, and then surgery for unstable joints. But usually surgery is a very last option, and it is reserved for only those joints whose joint destruction has taken so much that they have become unstable. And most of the time the option of these is actually arthrodesis of interphalangeal joints. We are not really left with good options most of the time. And usually the surgical option includes the arthrodesis of the distal interphalangeal joints. Thank you very much. Keep watching sqadia.com.